which, know a lot of people with bad breath, so.
Do you?
Maybe they got
Anybody want to call out?
We'll do it afterwards.
Hello, podcasting world. Welcome back to the Core Consult RX podcast, and we're live on Instagram. What's going on, everybody? What's going on, Mr. Cole?
I am doing great. How about you?
Can't complain, man.
Yeah.
It's been a minute since we've done one of these.
I know.
Again, I said this the last time we recorded.
I know. At least a week and a half.
Yeah, I think we're gonna lose all of our listeners.
Are we? Are we, guys? What do you think?
Probably not.
Probably not.
Yeah, it's definitely.
It's flu season. It's a crazy time.
It's been a crazy couple weeks.
Mm-hmm.
Super busy.
Yeah. For those of you who don't know, Dr. Corvino is actually taking up a new job recently, right?
That's what they tell me.
Yeah.
So
moving from the retail space into the clinical space.
Yes. So
I'm jealous.
I have moved from community, if you will, retail, whatever you want to call it, pharmacy over to a more family medicine clinic type pharmacy. I won't say the name just yet because I don't know if I'm allowed to, and I'll get back to you. But yeah, it's been pretty awesome, and so I'm spending some time staffing, going to be spending some time actually seeing patients, doing diabetes education, putting my CDE to work. There
you go.
And then we got a lot of stuff kind of in the works, looking at some specialty type situations and a lot of stuff, very, very cool stuff, a lot of innovative. It's one of the most innovation friendly organizations I've ever talked to.
On the cutting edge.
Yeah, it's awesome. Like anytime I've brought up ideas about things, they've jumped all over it and said that's a great idea. We should start looking into it. So it's pretty awesome.
Yeah.
So definitely very excited about this next chapter.
So it's going to give us all sorts of things to talk about.
Yeah, hopefully.
So when you text me and say, what do you want to talk about? I don't have to refer to my pharmacotherapy book and say,
pick something out of the table.
Pick something out of the contents.
That's right. So like, I'm trying to think of some stuff that happened this week that I can kind of think of just to give you guys some insight. We had a UTI patient that was very symptomatic, and they had started on, I believe it was nitrofurantoin originally. The patient was symptoms were getting worse, so they came back, and it turns out that when they got the culture and sensitivity reports back, patient was resistant. It was Klebsiella that was causing the infection, and it was resistant to pretty much every antibiotic they ran against it except for carbapenems. So we decided to go admit the person and down at MUSC and get treated with IV antibiotics, because apparently that was the only thing that would cut it. It was pretty crazy to get that report back and see all those R's for resistance.
I need some S's.
Yeah, we really needed some S's in our life. Not even
just
any
an
I's.
I. I'd be okay with an I.
Not even an I. All R's. It was crazy. It was a bad bug. But yeah, pretty interesting. And then yeah, just some random stuff. Got a question about H. pylori, which consequently enough, we're going to talk about that tonight.
I knew I studied that for a reason.
And so got a question about that, and it's been cool getting to spend some time with a lot of PAs, mid-level providers, which I don't think you're supposed to call them that anymore. I don't think they like mid-level.
No, I don't think they do. But if you look at CMS's stuff, they call them mid-level. So
well, I say it with all due respect.
There you go.
And some of the physicians as well. And it's been great. It's been a really cool experience so far. We'll see how it goes, and hopefully it keeps staying great.
Awesome. What's on the forefront of things you guys want to do?
I think the big thing is getting the diabetes education kind of rolling. One of my mentors and friends, whatever, just shining examples that's been really important in my career, Dr. James Starrett. He's been down there and at the clinic working, and it's something that he's kind of brought me in now to assist in what he's already started. And since he's kind of laid the groundwork and he's who really trained me when it comes to diabetes education, it's kind of going to be a very smooth transition, I feel like. And getting to work with him from being one of his students to now working with him is very cool. And so diabetes education is the big one. Getting the MTM services up and running, kind of with all the Medicare Humana and United Healthcare and all those different Medicare processing third parties. MTM was big for them, their star ratings and all that. So we're going to be kind of getting that rolling. And then from there, there's several little things in the works that I haven't fully jumped on board with yet. But as soon as I kind of get the green light, we will be all about it.
Awesome.
What about you, man? So you got some other stuff going on too besides just the community pharmacy?
Yeah, just working with some diabetes patients. Mostly helping them with diet. I feel like that's all we ever talk about. But
really?
Yeah. It's important.
Have we ever talked about that program on the show?
I don't think so.
Maybe episode 1, which
maybe
no one's ever really listened to?
Or maybe it was that episode 1 that we didn't release. And then a couple months later, we recorded the real episode 1.
It might have been the pilot episode.
Yeah.
The lost
episode. The lost
if you will.
episode. Yeah. I wonder if that's somewhere in the archives.
It's probably not because I just cleared a bunch of stuff on my computer.
Probably not. Maybe 10 years down the road, we'll see if we can find it.
Maybe.
Y'all
Probably
won't want to listen to it.
It was bad.
Yeah.
So let's tell them about that. We're both involved with this program.
Yeah, so it's a program through the state, the insurance in the state, and patients are able to meet with a pharmacist every 1 to 3 months, depending on how controlled their diabetes is. Because of that, they're able to get some of their medications and other diabetes supplies paid for, which is a little bit of an incentive for them. And also, they get to meet with us, talk to us about medications, what's been going on. Usually we talk about more than just medications and diet, a lot of things other than just diabetes as well. Sometimes their most acute concern is that they've been taken off a lot of their medications because they have an acute kidney injury and their serum creatinine's high. So we kind of talk about that a little bit. But the focus is on diabetes, and yeah, it's pretty cool. It's a lot of fun.
It's a good program. And I had one patient that came through there. When I first met him, he was only a year older than me, right? Maybe a year younger than me actually, but we're around the same age, and he had just gotten diagnosed with type 2 diabetes, and his A1C, I want to say it was like 13, 4, it was way up there. So he's put on, metformin, prandial and basal insulin, and I think Victoza as well. And he radically changed his lifestyle and changed his diet completely. I mean, like the fastest I've ever seen anybody changes their lifestyle. Started working out again, and like within 9 months probably, this guy's A1C was down to like 4 something, and
really?
he was off all meds, like completely off every medication he'd been put on.
All lifestyle stuff?
All lifestyle.
That's awesome.
Man, I mean, originally with the help of the medications and the insulin and all that, but gave his pancreas a chance to kind of rest for a minute and get back to normal, and now he's off all meds and not even on metformin. His A1C's super low, and
it's awesome.
He's really healthy, lost a bunch of weight. So it's a cool program, and it's a chance for us to kind of like sit down with the patients and spend much more than an office visit time frame. I mean, we really have like an hour if we want to.
Right.
And realistically, there's no time limit. We could spend more time with them if we wanted to. We try to keep it to no more than an hour. But
talk to them as long as we want. Much more time than an office. Much more time than even in a pharmacy if they came up to you to ask about something. For sure. So
especially in like a community like retail setting,
a busy one.
You have like 30 seconds.
You might not even have 30 seconds.
And you're behind.
Right.
Flu season. You're like, yeah, that sounds good.
I could have done 7 flu shots while I was talking to you.
Yeah. So it's which is depressing because a lot of pharmacists do want to be involved in patient care and can't because of the time constraints and all that. So that's a discussion for another time. I'll give you my rant about the metrics and all that nonsense. But yeah, so some cool stuff going on. Trying to keep it fresh so that we're not
always doing something different.
Yeah, it's definitely one thing I've been kind of shouting out for the last year or so on this podcast and others is keeping up with content, staying current, continuing your own education constantly, whether you're out of residency or school or whatever, and being ready to jump into the next thing. And so I felt very comfortable transitioning from a community pharmacy setting, retail setting, into this new role that I have doing diabetes education, almost like an ambulatory care setting. I felt very comfortable with that just because of all the time that I'd spent with outside of work, continuing my education, volunteering, continuing to make sure that I progress as a pharmacist. So trying to, all the nonsense that I spit on the podcast and whatnot, trying to make sure I live it out and don't sound like a hypocrite.
It's all nonsense. That's all we do.
That's right. But so huge benefit to staying current with information. But all that being said,
and you're already doing it if you're listening to us. So
yeah,
good job.
I mean, honestly, this is
kudos to you.
One of the best decisions you've ever made.
Might be the best one, the best commute you could possibly take
ever. I'm just kidding.
You probably listen to 4 of our episodes in a Charleston commute, honestly.
Yeah, no kidding. It's bad. Traffic's gotten outrageous.
It's terrible. Anyways, H. pylori. Aren't we talking about that?
Yeah. The very natural progression
right.
into H. pylori from traffic.
We're great at transitioning. But yeah, H. pylori, short for Helicobacter pylori. It's an organism that was more or less recently identified. Probably back in the 80s is when it became well known. A lot of people have it. Most people are probably infected with it around the world. They estimate about 50% of the global population has a chronic infection of H. pylori. So does that matter is kind of the question. Do all of those people need to be treated? The answer is no. But what does it do? It can cause atrophic and even metaplastic changes in the stomach. It also has a strong association with peptic ulcer disease. That's usually where you're going to hear about it. But it can cause other issues as well, or it's more, I would say, loosely associated with other issues. It's not like proven, but it can be associated with an increased risk for GERD, iron deficiency anemia, skin diseases, rheumatologic conditions, even inflammation of like the coronary arteries, and certain cancers. So it's definitely not to be taken lightly. But usually if you're going to identify it, it's because somebody's symptomatic and they said, okay, well, maybe we should test for H. pylori, which they can do through a fecal test. They can do it through a urea breath test. But you're probably not going to be tested unless you have some sort of symptom where the doctor's like, it could be this, right?
Yeah, and, I've talked to patients that when they describe being on, having H. pylori, and they thinking they just had really bad GERD at first, and I've asked them to describe like the pain they're having, and they said it basically feels like after they, when they eat or whatever, they feel like their end organs are, they're basically their organs are on fire, is what they describe it as. It's really, really rough.
Yeah.
Very painful. And, it's definitely something to consider long term. If you've been using PPIs for a long term, you're using them correctly, and they're still not taking care of the problem, then you go into a GI specialist and letting them take into consideration that diagnosis.
I think the signs and symptoms are kind of funny because, like I said, a lot of people are asymptomatic. But if you have symptoms, nausea, vomiting, abdominal pain, like you said, heartburn, hunger in the morning is a symptom. Mm-hmm. I don't know. I'm hungry in the morning.
I'm hungry in the morning also.
Pretty non-specific, but also halitosis, so it can actually cause bad breath. Which, know a lot of people with bad breath, so.
Do you?
Maybe they got
Anybody you want to call out?
We'll do it afterwards.
But, this is a good opportunity too, since we brought them up and talking about PPIs.
I thought you were going to say people with bad breath.
No, but let's keep that in our back pocket. But when you have a patient that comes in and they're talking about a PPI and saying that they're, let's say they're taking omeprazole and it's not working. One of the first things that, before you just jump to, it's probably H. pylori, make that diagnosis. One of the big things to ask patients about is how they're actually taking the PPI. PPIs, the way that they really work is, they have to be, they're all prodrugs. And so when they're taken, they are, absorbed, and then they are looking for that ATPase, that proton pump that is producing those protons, those hydrogen molecules, hydrogen atoms rather, that are going to cause the stomach to produce that, the acidic environment. And so when those pumps are activated, they shut those pumps off, and then those pumps are deactivated permanently until your body reproduces more pumps. The problem is, and a lot of people fall into this category of they've never really been educated on how to take a PPI, which it's pretty shocking how many people don't take it correctly. But they'll take it like with their dinner, for instance. In that case, it's getting into the stomach and it's becoming activated in the stomach. It's not allowing the PPI to actually be absorbed and turn those pumps off before they're ever as they become activated with the food. And so if you take it with your food, like right directly with a meal, most of the drug is going to get dissolved in the stomach and never absorbed. And then if you take it with, for instance, if let's say you go to bed and, because you have heartburn in the morning, you want to take it at bedtime so when you wake up, your heartburn's not there. That's great in theory, but unfortunately, the half-life of the drug, of a PPI, is only 1 to 2 hours. And so people always consider them 24-hour drugs, but that's only if they get to the site of action that they actually are meant to work at, and that's the proton pump. When they shut those pumps off, your body has to create new pumps, and that can take 24 hours or longer to produce those new pumps. And so if you take the PPI at bedtime and never actually shut those pumps off, you're going to bed and the drug's long out of your system. By the time you wake up, heartburn's going to still be there. So ideally, you have to take the drug 30 minutes to an hour before a full meal so that you can allow the drug to get absorbed, and then you can actually shut those proton pumps off as they turn on to produce the stomach acid. Not every pump is activated with every meal, and so they do take a few days to really take effect. But taking it appropriately, and then for a few days to kind of control the symptoms, and then taking it continuously for a few weeks or so to really suppress those acid producing pumps is the best way to go about taking a PPI just for regular GERD. And then if you have a patient that just cannot stick to a normal food schedule, a normal diet where they're eating all over the place, for like a healthcare professional, for instance, who doesn't eat at the same time every day, Dexilant, dexlansoprazole would be the go-to, because that's the only one of the PPIs that is not, it's not predicated on taking it with a meal. You can take it in just whenever you want, and it'll still shut the pump off, even if it's in an inactive form. So,
yeah, a couple weeks ago, I did the whole 14-hour day without eating, and it was not wise, but it was crazy. I blame flu shots. But the even with the other ones, other than dexlansoprazole or Dexilant, a lot of times they'll say take it before even the biggest meal of the day, because you might listen to us and say, okay, I'll tell them to take it before breakfast, and they eat a piece of toast and coffee for breakfast. So if lunch or if dinner is their biggest meal, then tell them to take it before lunch or before dinner. Also, the reason I think people they have that conception of they just take it and they treat it like a Tums is because if you go to the OTC aisle, it just fascinates me. Nexium, Prilosec, Prevacid, all OTC. Crazy to me. And they're right by the Tums. So Tums you just take, or Zantac you just take, and very quickly it starts working. So if that's what they've been using, because usually you start out with the Tums, then they might associate it with that. But there is different dosing. And that's really important for H. pylori, because PPIs are a mainstay of therapy.
Yes, absolutely. And so it wasn't what we were originally going to talk about, but I thought I'd bring that up just because it is important. It's something you'll definitely see.
That's relevant.
Yeah. Where do you want to go? You want to just talk and go into some of the therapies we can use for H. pylori?
Sure. I want to see if I had anything else, but I didn't. Other than it being transported through fecal oral route, which a lot are, but also oral to oral route. So stomach contents can be transmitted mouth to mouth, which sounds gross to me, but maybe a good reason not to drink after somebody.
It's not ideal.
No.
All right. So where do you want to?
So they have the three FDA approved triple therapies, which historically has been kind of the mainstays. Those are omeprazole, so the PPI with amoxicillin and clarithromycin, OAC for 10 days. There's also bismuth subsalicylate, metronidazole, tetracycline, which they call BMT, for 14 days. Then there's lansoprazole, amoxicillin, and clarithromycin, which is LAC. They'll either do that for 10 or 14 days. So historically, that's been kind of the go-tos, and they work, but they're kind of falling out of favor, I would say, right?
Yeah, so the clarithromycin-based treatments, one of the big things that we're running into is macrolide resistance, kind of in general, but H. pylori in particular are becoming more resistant to clarithromycin, and so that first-line therapy, that triple therapy, has kind of fallen out of favor a little bit in regards to being like the first-line agents. So some kind of risk factors that we would think about for H. pylori macrolide resistance would be if the person has had prior exposure to a macrolide,
Right.
which obviously makes sense, and then knowing your local resistance rates. So if the local resistance rates are 15% or higher, then you're going to have a harder time eradicating the H. pylori with just using triple therapy. And so you would want to probably use the quadruple therapy that's not based on a macrolide if you have a patient like that.
And if you work in a health system, you'll probably have access to some sort of antibiogram pretty easily, and
Right.
it'll have that information.
Absolutely.
Or just ask your pharmacist.
Well, when they may or may not have that information,
Right.
depending on what they know about the local resistance
That's true.
profiles.
And I should say that generally the triple therapies cure rate is about 85 to 90%. But like you said, in those macrolide resistant areas and for various other reasons, those rates are slowly declining.
Yeah. So if you are going to use triple therapy, which, again, was the mainstay for a while, triple therapy, you already said it has the PPI, the clindamycin, and then the amoxicillin. One thing that is to do consider, and I didn't know if you said this or not, so I'll repeat it just in case. If the person has a penicillin allergy, did you mention that?
No.
You can use metronidazole along with the clarithromycin, and that will still count as the triple therapy. It's done for 14 days, and the PPI will be, throughout the entire procedure to help hopefully heal. Especially if there's an ulcer present, will help heal that area.
Yeah, all of the triples are 10 to 14 days, but there are some 7-day therapies now.
Yeah.
And they've even looked at some 5-day therapies.
If you are going to move to a quadruple therapy, which I actually would probably recommend if the person has insurance coverage and can, is able to get it covered, it would be they call it the bismuth quadruple therapy. So you have a PPI still. You also have the bismuth subsalicylate derivative to protect the stomach as well. And then the two antibiotics that are involved are tetracycline and metronidazole. Those together. Now, the problem with those two, you have to treat them 4 times a day. So that is definitely the downfall. So the pill burden is a lot higher with using the metronidazole and tetracycline. The effectiveness, though, you're not worried about the clarithromycin resistance at all, and so it's something you don't even have to consider, and definitely something to think about if you're going to have a patient and you're even slightly worried about resistance rates. However, you want to make sure that they're going to be adherent.
Right. And like Mike said, the 2017 American College of Gastroenterology guidelines would say definitely consider that if you have previous macrolide exposure or if you're penicillin allergic.
Yeah. Let's see. What else? There's definitely other first-line options as well. There's triple antibiotic therapy along with a PPI. So still using quad therapy, but this one consists of using a PPI, clarithromycin, amoxicillin, and metronidazole, all 3 of those antibiotics at the same time for 10 to 14 days is another option that you can use. And then they have like a sequential therapy option, which is kind of interesting, where you do PPI plus amoxicillin for 5 days, and then you switch and you do a clarithromycin plus metronidazole for an additional 5 days. So it's 10 days total, but 5 days of one antibiotic, 10 days of the other antibiotic, or the combo antibiotic. So it's
just a little confusing when you do the old bait and switch.
I'm not a huge fan of that, but I'm sure there is a little bit of evidence for it. And so, if you have already tried and failed therapy with like quad or something, it would be something to consider to maybe, messing with the kinetics a little bit of the drugs.
Right. They also have the 7-day hybrid therapy, which starts with a PPI and amoxicillin for 7 days, followed by a PPI, amoxicillin, clarithromycin, and metronidazole. And there's various plays on these. I feel like for the most part, your health system will have a guideline for this, but not always, especially for an independent place. So just, check and see what they want. But like Mike said, sometimes it fails, and there are salvage treatments. Generally, you want to try to avoid any of the previously used antibiotics if possible. Can't always happen because, like you saw, there's a lot of overlay between the therapies. But yeah, you would want to try something different, avoid the antibiotics. And they have certain ones, like one preferred for patients who previously received first-line clarithromycin regimens. You might do a bismuth quadruple therapy or a levofloxacin salvage regimen. They do have options with 10 to 14 days of levo triple therapy, so levo, a PPI, and amoxicillin. Or a patient who received a first-line bismuth quadruple therapy, you might go with a clarithromycin or a levo-based salvage regimen. So whole bunch of options, a little more complicated than the simple 3 FDA-approved triple therapies, but there are a lot of options, and they all seem to work pretty well.
Yeah, and there's even an option for using a PPI plus amoxicillin, 1 gram twice a day, plus rifabutin, which is like a tuberculosis treatment.
Mm-hmm.
That triple therapy for 10 days has also been shown to eradicate H. pylori. Now, that would be considered salvage, so you would never typically think of starting somebody with that, but it is an option to, usually we would only see that used in things like Mycobacterium avium complex, MAC, or some of those other treatments like that are in patients that are immunocompromised, but that is a anti-infective agent that is effective against H. pylori as well. So kind of interesting. I have no idea about cost on that one though, which I'm actually trying to look at right now. I don't think it's all that pricey, but I don't know.
Well, you do that. A big question for me really is, when do you treat H. pylori? And I don't really have the answer to that. Like I said, if they're asymptomatic, you generally wouldn't have even tested for it. I remember that I knew somebody who was having some issues with weight loss, and they weren't really sure why, and they ended up testing for H. pylori, and the doctor told them they had it. And he didn't really think that that's what it was, but he gave them kind of the option, like, well, here's the deal, here's what you have. I don't know if this is necessarily what the issue is. Do you want to treat it or not? So he kind of put that in the patient's hands. Obviously, if you have PUD, or if you have significant GERD that is not being resolved, if you have anemia that he thinks, if it's any secondary morbidity that they think is being caused by the H. pylori, yeah, of course you would treat. But otherwise, there's so many people, it doesn't seem like it would be in the best interest of antibiotic resistance to treat everybody with H. pylori.
So, yeah, and one thing that's interesting is they do say that if the clinician is going to test for it, that they should, if they are going to test, they should be ready to treat.
Yeah.
So if it's something you suspect, but they're not, you shouldn't prophylactically just screen everybody.
Right.
But if it is somebody that's coming up with symptoms, or if somebody has, let's say, like early gastric cancer, would be one reason, an indication for testing. Somebody that has like a gastric mucosa-associated lymphoid tissue lymphoma, the MALT.
The MALT, yeah.
Then that would be an indication. Or, if somebody does have like a documented case of H. pylori in the past, obviously, if they're having the same symptoms again, they may not have been fully eradicated. So that would be a reason to test. But yeah, I agree. Screening would be a little ridiculous.
I didn't see much about reinfection, but I suppose that's a very real risk, as easily as you could get infected, right?
Mm-hmm. One thing also to consider would be if somebody has iron deficiency, because iron deficiency, especially if you're supplementing iron and you're still having deficiency, H. pylori can actually interfere with the absorption of iron. And so if you have like a kind of unexplained iron deficiency,
might be one
that
thing.
would be something to consider. Trying to think of anything else like
with the PUD, just because you're at such high risk generally with somebody if they have confirmed H. pylori. I guess if you were testing, then we just kind of reason that you would want to treat it, but if not, you do want to be careful with NSAIDs, because those patients are going to be at higher risk for GI bleeds, and aspirin, of course.
Yeah. The other thing I thought was kind of interesting is, like, you mentioned the urea breath test earlier as one of the screening potentials of that. But the reason why I guess that's even a possibility is the H. pylori themselves, they attach to those gastric epithelial cells and they bind to like this specific receptor, but they actually hydrolyze like the gastric luminal urea to form this ammonia, which basically neutralizes the gastric acid, and it forms like this protective cloud around them, which is one of the ways that they're able to remain safe and then penetrate that gastric mucus layer and cause the ulcer in the first place. And so because it's giving off that byproduct, that urea breath test is able to kind of signal that and see where it's coming from.
So it's very specific for H. pylori, and the fecal antigen test is actually pretty specific and sensitive. 98% specific actually, and 94% sensitive for positive results obtained. There's also an H. pylori serology, which has pretty good specificity and sensitivity. Useful for newly infected patients, but not as good for follow-up treated patients. So I guess there's a reference to the reinfection. But I hear about the breath test a lot.
Mm-hmm. And, H. pylori definitely can cause gastric ulcers, but a lot of times they're more commonly found in the duodenum. So duodenal ulcers are more commonly seen with H. pylori. Now, if it's an NSAID-induced ulcer, then it's probably going to be a gastric ulcer. But, one of the things about the duodenal ulcer and because it's a high risk of H. pylori infection causing it, if the patient is saying that the pain is worse at night, the epigastric pain is worse at night, or if it occurs, after like several hours after a meal, and a lot of times they'll even talk about the pain being relieved by eating, that's more indicative of a duodenal ulcer, which would probably be caused from an H. pylori infection, versus a patient that's having epigastric pain when they eat. It's probably more in the gastric ulcer, causing that, and that can be from taking aspirin on an empty stomach every single day, which I have seen. Popping aspirin because it's delicious.
Oh yeah, literally tastes like candy sometimes. Yeah, I said that 50% of people are infected, and it is highly associated with peptic ulcer disease. So H. pylori is probably going to be found in about 90% of patients with PUD, but less than 15% of infected persons may actually have PUD. So H. pylori doesn't necessarily mean PUD, but if you have PUD, you probably had pre-existing H. pylori.
Yep. So, yeah, H. pylori.
Fascinating.
What's up?
I first heard about that from my mom, actually.
What?
I don't know. She got to looking through, and she's like, did you know everybody has this H. pylori? And I'm like, this is like early in pharmacy school. That was the first time.
So, yeah, we do.
I probably have it too.
That's why I take amoxicillin every single day. Make sure
every day of my life.
Every day. Prophylactically treating myself.
Speaking of infectious organisms, have you heard of the hookworms in the South from like the late 1700s, early 1800s?
I have not.
So apparently there was a hookworm, or there still is in a lot of developing countries, but in the American South there was a hookworm that you could obtain through stepping on it, and it would go from your feet into your lungs. You would cough it up into your mouth, swallow it, and then it would live in your stomach. And it was very clearly associated with like stunted growth and lower IQ. And they think that it's where Southerners got the whole stigma for being kind of slow and Southern-like.
Southern-like.
Yeah.
That's weird.
And there was this whole campaign in the early 1900s by the Rockefeller administration to eradicate the hookworms.
Were they selling the antidote?
Yeah, they're basically selling the antidote. Those Northerners.
Interesting.
Yeah. Anyways.
Hey, you guys know how you're real dumb down there? Well, we got the perfect solution.
We can fix you.
That's interesting. Where did you see that at?
A podcast. Yeah.
We should do some research and find out if that's like legit.
I think it's legit. It still goes. It's still a thing. But the whole like Southerners being I don't know if that's legit, but the hookworm thing is very legit. Yeah.
No, I mean I believe the hookworm. I'm just thinking about like
the stigma. Yeah.
Are we also shorter than?
Apparently that it caused an iron deficiency, because you could have like up to 100 worms living inside you at any one given time, sucking a teaspoon of blood a day.
What a bunch of jerks.
I know. So apparently iron deficiency, and it caused issues like that. Stunted growth.
Interesting.
So others might be shorter.
You heard it here first, folks.
Yeah, that's the first one to bring it up.
The podcast that actually reported on it. That's cool.
Yeah.
What podcast was that from?
Stuff you should know.
Stuff you
I'll
should
give them a
know.
shout out,
There
but
you
they
go.
have enough.
I was gonna say I don't think they need our help.
They don't need our help.
Not even a little bit.
No, they're awesome though. I love the podcast.
Hey, that's cool.
Yeah.
All right, man. Anything else? It's good to get an episode knocked out. We
I
gotta
know.
make sure we get caught up and have a lot more posted.
Yeah,
from-
we'll pump
from
them
here
out. That
on
was a good one. Part of our GI suite.
Yeah,
We've done.
that we have.
Well, we've done Crohn's
Yeah, we did.
or Crohn. Who knows? But
Yeah.
one or the other.
One of the two.
Is that the only one?
Could be plural. Could be
singular.
singular.
Yeah. I think that was it. That was the only abdominal one. So good. We got 2 GI ones.
Good. We have a GI suite.
Yeah,
A GI playlist.
We
if you
should
will.
we should never try to relive the podcast on the episode because we can never remember.
We always look like complete morons.
No idea what
What
we
have we
recorded.
talked about?
I have no
We have a podcast.
clue. That was us back then.
Oh my gosh.
Last week.
Yeah. So we'll get back on the trail of actually putting them out more than once every month like we've done the last couple. So I appreciate you guys sticking with us. Appreciate all the new listeners we have. I've noticed the numbers have been going up pretty drastically, so that's been awesome. Thank you guys so much. If you do like the podcast, and regardless wherever you listen to it, Spotify, iHeartRadio, iTunes, wherever, we would definitely appreciate if you hit subscribe, or if you like the video version on Facebook Watch or on YouTube, we would definitely like a subscribe or a share. That'd be awesome. And then if you have time, we would absolutely love to hear your feedback, get a rating from you on iTunes or wherever else allows you rating, mostly iTunes. And that would really help us out as well. So thank you guys so much for the support, and we will see you next time. Later.